Well, welcome everyone to this presentation by Dr. Ned Calonge, our finalist for the position of Associate Dean for Public Health Practice at the school. By way of introduction, Ned is a true Coloradan, having been born here, growing up here, and spending most of his professional career here, except for time away for training. Ned is a graduate of Colorado College, the University of Colorado School of Medicine, an MPH obtained before the Colorado School of Public Health existed from the University of Washington. He's had long involvement with this campus and with the School of Public Health, having held academic appointments and holding a secondary appointment in our Department of Epidemiology and teaching there. Among the many positions he's held, he recently stepped down from his role as president and CEO of the Colorado Trust, an important grant-making foundation directing itself at health equity in Colorado, position he held more than 10 years. He was with the Colorado Department of Public Health and Environment, including serving as chief medical officer and state epidemiologist. He was with the Colorado Permanente Medical Group, and at the start of his career was in the Department of Family Medicine. Ned does a lot, has done a lot for Colorado and for the nation. He's held leadership positions in Colorado and nationally. I'll mention at the moment he is chair of the Community Preventive Services Task Force of the CDC. This is a group that decides what works for disease prevention at the community level. He's very active in the committees of the National Academies of Science, Engineering, and Medicine, and is an elected member of previously the Institute of Medicine, now the National Academy of Medicine. He's published widely on practice issues. And among the honors he holds beyond the Institute of Medicine is being elected to the Delta Omega Society, our honorary public health society, in 2013. So I'll just end by saying that Ned is also a master beer maker, and don't know that he's going there today, but he's well known for that. So thanks, Ned. We're delighted to have you here as a finalist for this position. And what we'll do, everybody who's on, Ned's going to make a presentation. Then we'll just have an opportunity to talk with Ned. I think that the group is small enough so that you can perhaps put a question in the chat, but then we'll promote you up so we can have a live conversation. So Ned, please go ahead.
Thanks, John. I'm going to try to share my screen. And can everyone see just one slide?
Yeah, you're good. You're good.
Okay, thanks so much. So I try to think about what would be interesting for the group to talk about in terms of the position of Associate Director for Public Health Practice. So I thought I'd step back and look at public health in kind of three different areas. And there we go. So I want to just remind the folks of the elements of public health, and then for redesign, talk about infrastructure with a focus on emergency preparedness and response, which I think is timely today given the pandemic. Then an area of passion and an area that the school has really made advancements in, which is addressing social determinants of health and health equity. And then kind of close with thinking about bridging and collaborating with healthcare as a public health system in terms of practice moving forward. So I wanted to start with kind of what is public health. So I know that sounds funny to present to a school of public health, but I think it's always good to remember what the rest of the world thinks about public health. And unfortunately, I worry that this is currently our brand, that we're this evil devil that's promoting and mandating masks. And we've become so politicized that we've lost control of our brand. And I would like to kind of return to the brand I think we should have. So I think a lot of you might know what this is a slide of. This is Broad Street in London. That is the Broad Street pump. And here is the first public health intervention saving thousands of lives in London during a cholera outbreak. And you see that the pump has no handle. So removal of the pump handle was the first major public health intervention in response to a disease outbreak. So I think coming back to what public health is, and it's amazing to me, we can go back to as early as 1920, and Charles Edward Winslow said, it's the science and art of preventing disease, prolonging life and promoting health through the organized efforts and informed choices of society, organizations, public and private, communities, and individuals. And I think we need to make sure that our brand really reflects what we've been trying to do since 1920. Many of you may have heard of the 10 essential services of public health. These were actually revised just 2 years ago by CDC and the De Beaumont Foundation. And it reflects the previous version, but just kind of updates a little bit and talks about monitoring health status and the factors that influence health, communicating effectively to inform and educate, mobilizing communities and then partnerships to improve health, championing policies, plans, and laws that impact health, meeting our regulatory obligations to improve and protect health, making sure there's an effective system for equitable access to individual services and care, building a diverse and skilled workforce, improving and innovating functions through evaluation, research, and quality improvement, and build and maintaining a strong organizational infrastructure or system for public health. So I think as I think about public health practice, bringing these to life in terms of specific activities is a big part of what public health practice is. So thinking about infrastructure, I wanted to kind of remind folks of the elements of the public health system. So we have preventive services, maternal child health, infectious disease control, which we know a lot about today, environmental epidemiology, which is becoming more prominent as we move forward, public health emergency preparedness and response, which I'll call FEPR from here on out. And then there's the environment in terms of food and water safety, air quality, hazardous waste control, medical regulation of providers, facilities, and services, our data, both health and environmental, and the national public health is a little bit more, I would say, nuanced. And I always point out that CDC has very little direct authority over state and local public health. And it really achieves its goals by being an authoritative partner with direct assistance with expert staff and through funding and national programs, including this group, the Prevention Public Health Fund, the block grants, preparedness grants, other specific program grants, and things like the Vaccine for Children program. And as John mentioned it, I had to throw in, there is a whole guide to evidence-based public health preventive services for public health recommendations at the state and local level. At the state level, I think we need to recognize that most state health departments receive little funding from their primary state. And when they do, it's almost always program. And our staff all depend on it. Most states meet local public health objectives by providing that same expert assistance and then sharing federal and state funds with local public health departments. Often, again, that's programmatic, although Colorado enjoys some core funding through state statute. And then state health departments really take the lead at creating state public health policy, working with the local partners. It's a complex system that involves state health agencies and then city, county, and regional health agencies, then our state legislators, our county commissioners, and other city officials, public health partners and affiliates, and all funded through federal, state, and local taxes and grants. So it's a complex system. And when you think about public health, successful in meeting the vision of public health. At the local level, this is a true front line of public health practice. The local branch of state health departments, depending on the structure of the state. So in Arizona, for example, there is a single health agency. It's the state health agency, but they have offices in the different counties. These local health departments are funded with federal, usually through the state health department, state and local dollars. And one of the things we notice is the robustness of the service often depend largely on the size of the service area, not in terms of geographic area, but the size in terms of the population. There are other agencies for collaboration, although I have to point out that between state agencies and between state and local agencies and with federal agencies, collaboration is highly variable. And I'm really excited to be able to say that sometimes, like in Colorado, there are good collaborations with academia and schools of public health. Level, we have CDC, but we also have the Health and Human Services Office of the Assistant Secretary for Preparedness and Response. So this is ASPR, and the idea is that there's more to emergency response than just the public health response. And I kind of like the idea of ASPR conceptually, but now that you have two different federal agencies in different parts of the federal government in charge of the same activity, that adds a level of complexity that often gets in the way. Also in the infrastructure are state health departments, and then again, local health departments. And then there are other emergency management agencies, both at the federal level with FEMA and Human Services, but then also at the state level in emergency management. And again, trying to think about a single coordinated response to an event that has to be coordinated through all these issues, through all these levels is a real challenge. What about the funding for FEPR? Again, almost all preparedness funding is from federal sources. It's seriously decreased since the big influx in 2002, which was in response to anthrax letters, as well as 9/11. And then, so the farther out we got from 2001, the less interest there was in funding effective FEPR activities. And then in the years that immediately preceded COVID, all of this funding was all but eliminated. There was a small bump transiently with Ebola, but with the previous administration, kind of thinking about emergency preparedness kind of took a much lower priority, which is one of the reasons I think, were so slow in response to the pandemic. So now we know what a COVID-like event needs. I think evidence-based recommendations for public health response, and folks need to know that this is ongoing. I mean, I listened to a presentation from Molly Lamb and her, I'm forgetting the lead author, sorry, Molly, but on specifically around masks use and how different breathing patterns for different level of infections are picking up super spreaders or non-super spreaders in a different way. So all this evidence is going to continue to occur as we sift through the response, and we can get ready for the next event with more evidence-based recommendations. Then we need strategic planning and message development and communications that's better suited for all population segments, especially marginalized peoples. We need to be able to have coordinated testing programs. Now we know there's a huge need for support for residential institutions. John and his team have shown that data tracking and modeling are essential in providing evidence-based recommendations to the public and to state agencies, contact tracing, and then population-based immunization. So we have experience with all these, but learning from that experience and creating a system that's more prepared is, I think, an important issue in practice moving forward. So if we're going to redesign for FEPR, we need to think about people in terms of training and numbers, the relationships, both structural and relational. I think we need to think about communications, both in terms of the message, content, style, and the mode of transportation. We need to do this all within contexts of different scenarios, political settings, economics, and community trust. And most of all, we need to think about funding. From funding, we need support that's sustained for emergency preparedness, services, and research, and it needs to be immune to how long it's been since the last crisis. We need to have dedicated funding to support horizontal and vertical relationships and collaboration, which could be created through administrative structure. We have to assure a trained public health workforce, and we need now to invest in activities to restore belief in science and to depoliticize public health. There are challenges to these redesign issues. Our economic and social culture doesn't like to create and sustain unused capacity, but we need that reserve capacity to assure public health preparedness. The challenge is seen both in public and private sectors. Public health is seen as a state and local function, though with significant federal funding. And there are many competing priorities for state coordinated is something we really need to think our way through and create policies and practices that allow us to get better. Another challenge is this phrase from my friend Mark Johnson, who just retired from Jefferson County Public Health, that politics and prevention are natural enemies. That is, no one ever gets elected for something that was prevented. So I think thinking about redesign around emergency preparedness is a key activity to think about, and it needs to be engaged at the state, local, policy, and national levels. I couldn't come from where I just spent 10 years and not talk just a little bit about health equity and public health. And I know you all know this. I think the Centers for Public Health Practice have done just a great job, and I really admire all of the work of Dean Hunt and her team. But to remind people that Healthy People 2020 says it's the attainment of the highest level of health for all people, and that it requires valuing everyone equally. It also requires focus on ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and eliminate health and healthcare disparities. The other part of that's important to define for health equity are the social determinants of health. There's been criticism of this phrase from a lot of different feelings that determinant sounds like you can't change it. But in epi, we always think about what things are associated with. And this is the term of art that I think we're using. So what are the social determinants? And those are the circumstances of illness. But all of these are in turn shaped by a wider set of forces, including economics, social policies, and politics. I like to think about the social determinants of health in terms of opportunities and barriers in these big buckets, starting with kind of education, then turning to income, then thinking about the physical environment in terms of housing and public safety and food, and then social justice issues of structural racism, culture, political clout, and justice, and then the environment in terms of exposure to pollution and hazards. We did a study at the National Academies of Medicine, Communities in Action. It's a report that's available on the NAS website, but I like how we frame the root causes of health inequities. The root causes being the unequal allocation of power and resources, including goods, services, and societal attention, which manifests itself in unequal social, economic, and environmental conditions. There's structural inequities that organize the distribution of power and resources differentially across lines of race, gender, class, sexual orientation, inequalities are at the core of achieving health equity. I just wanted to give just a few quick examples of what could happen. Were we able to address these? This is the impact of resolving racial disparities in the US between 1991 and 2000. This was done by a good friend of mine, Steve Wolf, who's at VCU. And it's an old analysis, but he's never repeated it. But what he found was that there were, in that 10-year period of time, 886,202 deaths that could have been averted if we corrected the disparity in age-adjusted mortality rates for African Americans versus whites. There's another favorite slide of mine that shows the impact of educational attainment and mortality. And you see the higher your education, the lower your log odds of mortality. And then there's this really interesting point of discontinuity between education leading up to high school graduation and high school graduation. And there's not there's not like something magic that happens if you drop out a month before graduating versus not. Your education is still the same attention, but the degree itself gives you a life trajectory that gives you a number, a measurable change in your log odds of mortality. And then you see after high school graduation, it just, the curve gets steeper. How does this translate to Colorado? So these are high school graduation rates from 2015 to 2016. They seem a little old, but I didn't go back to redo this slide. But I wanted to point out these differences between whites and Asians, and then Hispanic, Black, and American Indians, and that telling you that these gaps represent life years that we are losing because we're not providing an equitable access to high school graduation for our students across the spectrum of race and ethnicity. Similarly, here's a fairly recent study by Chetty that was looking at the level of household income and life expectancy starting at age 40 years. And he found that there was 1 month increase in longevity for 1 percentile of household income. To put that in perspective, mammography for women 50 to 74 provides about 3 months increased life expectancy. And here, 3 percentile in household income would attain the same life expectancy. How does this translate to Colorado? Well, this is the Colorado median household income. You see a similar pattern with Hispanics, Blacks, and American Indians, all having much lower measured median family incomes. And this difference, again, translates to real life expectancy in our own state. If you roll all these up, this is one of the areas where Robert Woods Johnson gets their phrase, your zip code is more important than your genetic code. This is a map of life expectancy for the Denver County. 73 is at the low end, 84 at the high end. And so here is a life expectancy of 73 that is less than 5-minute drive away from a life expectancy of 84. That 11-year difference is the same life expectancy you lose if you're a lifetime smoker. And so these are the issues that I think public health needs to look at a map like this and say, we are not doing our mission if we're not addressing the issues that form the public health system. This is the Bay Area Regional Health Inequities Initiative, and it talks about upstream and downstream services. And we spend most of our time downstream here, a lot here in healthcare, in disease and injury. But policy goes across all of this. And the idea is that we are trying to move from current public health practice along the bottom to emerging health practice by moving further upstream to address social inequities, power, living conditions, etc. All right, so I'm going to try to wrap up, John, by spending a little time talking about working with the healthcare system. We talked about what the public health system was. What is the healthcare system? Well, one of the problems with the healthcare system is it's not a system. It's a loosely confederated group of disparate systems, all that have their own factors that motivate them and things they're trying to achieve. Part of that is health, and part of it is making money. We have the private insurance sector, then we have government-funded care systems. We have separate healthcare facilities and emergency transportation. We have providers and regulators. We have payers. We have industry, including pharmaceutical, device, and information technology. And we can't ignore the impact of the legal and tort system. And this whole system is funded by individuals, businesses, and federal, state, and local taxes. Where is there overlap with the public health system? Well, these are the ones that they're easiest to find. There's medical regulation, infectious disease, immunizations, injury prevention, maternal child health, including newborn screening, response to public health emergencies, and the prevention of chronic disease. I wanted to talk about how we're doing and what we could be able to do. So this is a slide based on pre-COVID Colorado mortality. I would need to revise this to address COVID. And so it's a little less realistic, but we've been through COVID. We know we need to be better prepared. And I wanted to talk about the pre-COVID world in terms of how we could do better with interacting with healthcare. So the numbers are a little higher now, but in general, we have about 30,000 deaths a year. 6,500 are those due to cardiovascular disease, 1,500 strokes, and then about 6,500 cancer deaths that are broken into lung, colon, cervical, and breast. And I picked these because we have a good primary prevention strategy for lung cancer, and we have great screening tests for these other ones, or at least fair screening tests. How well do we do in these areas? Well, we still have 17.7% of the population smoking. We have 22% obesity. This has actually gone up since this slide was made. It tends to be a number that just continues to go up. We have 604,000 adults with hypertension who are untreated. That's about half of all. And then 400,000 of those aren't treated at all. So that means 33%, or a third of those with hypertension, are not identified and or treated. And this is one of the most effective clinical preventive services we have. We have over 800,000 adults with hyperlipidemia who are undertreated, and 50% are not treated at all. We have 170,000 women who've not had recommended mammography, about 170,000 women with not recommended pap smears, and over 300,000 adults not having recommended colorectal cancer screening. What this means is that we're losing lives that we don't need to lose. And when we sum those all up across taking the effectiveness of the preventive intervention and applying it, we're losing 16,000 deaths a year. More than half of all deaths in Colorado are preventable. If you translate to life years, that's over 200,000 life years per year that we leave on the table, that we're not addressing because we're not using, not the fancy, exciting things like CT scanning for early lung cancer treatment, but these things that have been around for so long, we should be better at them. So what's the problem? A lot of the issues are about health fall into gaps, and the gaps are between the insurers, the providers, and our facilities. And many critical health issues are not well addressed by episodic individual provision of personal health care systems. And we know that the benefits of prevention will be maximized if they could be applied at the population level. But we have this schism between public health and healthcare. And the problem here is the skills and knowledge and experience required to move beyond the health and disease of the person in front of you in the exam room doesn't translate well to addressing the health and disease of the community and the population from which those persons come. Unfortunately, or fortunately, depending on, I suppose, how you look at it, our culture values individual health above population health. And while we are partners with the healthcare system, the partner with all the money may be the wrong partner. So think about expanding the role of public health. A lot of these things we're already doing, but we need a system that provides an effective preventive services to the community. That includes cancer screening, newborn screening, heart disease prevention, diet and exercise, education and counseling, infectious disease screening, counseling and treatment, smoking prevention, smoking cessation, immunizations, and family planning. And all of these services then need to be integrated with the healthcare system. So let me just end with thinking about moving beyond the prevention space into chronic disease management, the last public health frontier. I'll point out that the Community Guide to Preventive Services Task Force has a lot of recommendations that are management issues for chronic diseases. And we know there are many of those that will benefit from care coordination and evidence-based guidelines. Just to mention a few: asthma, diabetes, and congestive heart failure. Now, these are done in integrated systems of care, but outside of those, the programs are delivered in a fragmented and non-integrated function. And just like prevention, if we want to maximize health impact, care management has to be delivered on a population basis. And who has the tools to achieve that? Public health. So the elements of chronic disease management would require a shift in the funding structure. We need more robust data system of registries, chronic disease guidelines, and protocols, which we could achieve through electronic medical records and our existing reportable disease designations. We need people, trained professionals in public health, in patient navigation, and community healthcare work. And then all of these need to be integrated with public health providers. So I would like us to think about envisioning this brave new world of public health practice with rebranding and redesign that includes medical regulation, because frankly, someone has to do it. But then infectious disease control, including epidemics and pandemics, a robust and ongoing emergency preparedness and response system, upstream interventions to address the social determinants of health and promote health equity, continued emphasis on air, water, food, and waste and environmental health, preventive services that include immunizations, health education, behavior change counseling, disease screening, and risk factor treatment, and then chronic disease management. And think about this new world and this approach to public health practice and what that could mean to prolonging the life and improving the quality of life of Coloradans. And that's where I would like to stop, John, and see if there's any questions.
Great. I'm sure there will be, Ned, and thanks so much. You laid out a lot of work that needs to be done. And of course, that's always going to be the case. I'm going to lead off with a few questions, but again, let me ask that those who want to comment, Bobby will make it possible for you to speak. So yeah, actually, Linda, why don't you go ahead, because I think you and I were about to ask the same question, and fire away.
Can you hear me?
Yeah.
Yes.
Okay. Well, thank you very much for that talk. I really liked your vision, of this redesigning public health systems. So, but I'm thinking of the School of Public Health here at the university. And apart from just training in general, could you please provide some specific actions that an academic school like this could do to achieve some of the goals that you presented?
Yeah, so thank you for that question, Linda. And I think the great thing about the school is that there's so many activities going on. I can actually point to some that are already being looked at. So if you think about translation of prevention activities into actual health, the Accords program, in terms of really trying to implement what we know works in public health and in clinical medicine into translating that into practice, into the real world, is one of those interface areas. Another is that there are at least two different policy shops. So a lot of the redesign needs to be achieved through policy at the local, state, and federal level. And so I think about the Center for Public Health Practice and their policy work. And then I think about Glenn Mays and his work in kind of health policy moving forward. And there's kind of a rich group of faculty folks who are working at those interface areas. So those are just a couple of that come to mind. I think another thing is helping local public health and state public health do a better job of engaging at the community level and using that community input through public health practice to really bring the force and the power of people in community to the table in terms of designing systems, strategies, and relationships that will actually help achieve this vision. Part of the vision can be achieved through fostering partnerships and collaborations to try to achieve the things we want to achieve. But honestly, a lot of it will need to be policy and funding based. And so working at the state and local level with the kind of evidence that a School of Public Health can bring to the table is where I see the interface would work best.
Thanks. Ned, say something about how we think about engaging our faculty and staff and students as key assets in public health practice, and going along with that, what do we teach our students about public health practice, and how do we prepare them? I mean, if you're aware, of course, that for the MPH degree, we have competencies that, our CEF lays on us. And of course, public health practice is embodied within it. But just say a little bit more about sort of advancing the profile of public health practice within what we do and within our educational portfolio.
Right. So Don, I think that's great. I mean, I'd be really interested to know within the student body, how much of that first part of the talk around what is public health was brand new to them. How many of them know that there is something called the 10 essential services of public health? I think focusing on bringing up what public health practice looks like in a very formal way, I think is something that is woven in through a lot of the other courses and definitely part of the practicum, but maybe not looked at so specifically as this is public health. I was looking at the slide, I think I called the public health system, and not the infrastructure, but it kind of went through a number of topics. And I was thinking about that just this morning, that's almost like the specialties in medicine. So a student could say, I am really interested in environmental health. And how could I, in my training, focus a little bit more on achieving the skills or attaining the skills I need to be marketable in that specific area? And so one of the things I thought about was, how could we take that list and have MPH students really think about where my interest lies and how would I like to best poise myself for a position in in state public health in the prevention space, or in local public health and disease outbreak investigation, or in policy work in terms of working with policymakers at the state and local level. So I think intentional education about what public health practice is, both to the students, and then I might feel like to our faculty as well, and then thinking how the product of the School of Public Health, the students who graduate in the various degree programs, how we can best create a system that allows them to gain the skills and knowledge they need to be successful when they graduate. I know there's an activity that's actually asking the departments to say, what do your partners want? What is it that we need to be training, so that in the accreditation process, we can show that we're crafting our educational system to really address the needs of the communities that will hire our graduates.
Great, thanks. Let's see, we have a couple of questions. I'll go to Lori, and then I have one in the Q&A I'll go to. So Lori, please.
Yeah, hi, Ned. Thanks for that presentation. I do want to say that our students should know the 10 essential services, or 10, yeah, is that what they're called? 10 essential, I don't know what they are, but our students are supposed to be getting that in a course called Foundations in Public Health. So hopefully they do know. But I wanted to ask you, Ned, you laid out a really expansive, comprehensive view of public health. And you mentioned the need to work on policy. And I wondered if you could get specific about what of all the different types of policies we might work on, what is one that you would take on? Because after listening to your comments, I kind of think we need to get our graduation rate up for high school and sort of step maybe outside of those things that are directly related to disease and really work on those social determinants.
Well, it's a great question, Lori, and I think there's kind of two answers to it. So the first answer would be, I always, unfortunately, believe in being opportunistic. So there was, we got $17 million a year in federal dollars poured into emergency preparedness on the basis of 7 deaths due to anthrax in the mail system. I want to point out that that's 7, and at the time, 300 million people. It would be nowhere on the list of important health issues. And yet it drove this huge influx of funding. I think, as I look at the feds moving forward, that trying to better poise the healthcare system, the public health system, to respond to pandemics is an area of active discussion between CDC and congressional leaders. And I believe that that will translate to real funding opportunities. It will be siloed again, though, in terms of public health preparedness. And we shouldn't miss the opportunity to back up and to improve our preparedness and response activities as a core activity, and leverage those funds to the other areas of public health. Plus, inherent in that, in those policy issues, are kind of health equity issues about making sure that both recovery from the pandemic and our preparedness for ongoing issues puts equity at the center, so that we look at an equitable recovery. In terms of public health, looking at education, I think the first thing we need to do is recognize the relationships, and then think about how public health at the local level gets beyond outbreak investigations and animal control and restaurant inspections, and really starts to come together with schools and school boards and superintendents. There's a whole system that we've not well tapped into, of looking at relationships about how to improve activities, especially for students of color, in attaining very simple education, simple for me to say. How about primary educational attainment that we need to be doing a better job at. And as the keepers of a lot of knowledge around how to engage marginalized populations, I believe public health can bring things to the table. One of the things I've talked to, I think in every discussion with the associate deans, is how real-time interpretation services, especially for communities whose primary tongue is Spanish, can really make better relationships and allow Spanish speakers to better engage in public policy, even at the level of school boards and city councils. It's called language justice. It's allowing people to process and participate in the language of their heart. And we've seen it in philanthropy make a huge difference. So those are just a couple of things to answer the opportunistic issue and then the most important issues.
Thanks. We've got a bunch of questions lined up for you, Ned. So this one is about just your thoughts in general about how workplace occupational health plays in the broader context of broader picture of public health practice.
Yeah, I didn't really talk much about occupational health. And if you think about, I always talked about when I did health worksite wellness for Kaiser Permanente, I would always point out that people go to work way more often than they go to the doctor. And so if we're really trying to create a system that impacts people's behaviors, we need to think about engaging where they are. And so part of that is occupational health, and part of that is worksite wellness. And those are very, they're related and they're different in different ways. And I really believe that focusing on worksite health is an important issue. The community guide has a number of recommendations for interventions that are known to be effective at the worksite level, primarily, again, not in the OCMED space, but in the worksite wellness space. And so that, for me, is an area of interest and passion, and I think related, a partner, if you will, of occupational medicine.
Thanks. And speaking of workplace, Lee Newman.
Yeah, thanks very much. And thanks, Ned, for that talk. If you get this job, we'll spend some time talking about total worker health in a more comprehensive way than worksite wellness, but we'll come back to that. I did want to ask you, though, about what I think is the existential threat. I haven't heard you say much about climate change in public health. What's your vision of how the Colorado School of Public Health students and faculty can participate from a public health practice standpoint to contribute solutions on climate change and public health?
I think the school actually has an interesting footprint in the area with looking at the public health impact of oil and gas extraction. That is kind of a unique position that I haven't seen repeated in a lot of schools of public health across the country, but it's an important additional reason to start to think about limiting oil and gas extraction, which could be at the heart, if you will, of starting to shift the dialogue around climate change. We're also an interesting state in that we made huge, I believe we made really huge, important advances in policy under the Ritter administration, where climate change and oil and gas emissions limitations and solar and air and alternate forms of energy were a very big part of his political vision. And interestingly, he was followed by John Hickenlooper, another Democrat, who undid most of those policies. And so not all of them. So I think a lot of what John did was good. And I think that industry did better under him. And Polis has been, I think, kind of moving a little bit better. There's so much influence that the governor's office has over this agenda that I think the best we can do is try to think about how our policy folks, our policy shops can work with state and government legislators and the governor's office to bring climate change issues up to the policy level. How can students participate in that? I think thinking about how they do research about the link between climate change and health, and then really through Cerisa's work, focusing on environmental justice and how environmental exposures differentially impact people of color are just a couple of areas I would be really interested in pursuing.
I will say, I mean, I think certainly one thing I've observed, is I'm sure others have, is that this is certainly climate change and health is just becoming a dominant issue with the younger generations, as it should. Let's see, Jan Lowry, do you want to? Let's see, Jan, do you want to go ahead and pose your question, or?
Yeah, can you hear me?
Yeah, I can.
Okay. Hi, Ned. It's great to see you.
Great to hear from you, Jan.
It's been a while. Enjoyed your talk. Really appreciate the comments you made around integration of public health into healthcare and / healthcare systems. I firmly agree with you. I mean, as these systems are sort of, I like to think of gobbling up all these primary care around the state, certainly serve a large part of our population here. So my question, Ned, now that I have experience working with a couple of these in Colorado, is who's the natural partner within these systems? You know, a while back, I used to think population health, you know, many of these systems have directors of population health, they have teams now, but they're almost, it's just not quite the same. I mean, I thought it would be a natural relationship, but they seem to be more interested in risk management. So I'm just wondering what your thoughts are on that. If you were to try to broach that here in Colorado, who are those important natural partnerships within healthcare systems with public health?
Yeah, one of the important levers that we still have is Ncqa Accreditation. And when I was at Kaiser, that was my best lever to pull on. That we competed on our ability to show how well we were doing on a population level with known effective preventive services. That was within Kaiser Permanente, but the other healthcare systems can no longer ignore that. And so I think if you think about United and you think about Anthem and you think about Cigna, they have looked at people in prevention positions who are thinking about prevention across systems. One of the problems with that I don't have a good sense of how to crack is the decisions that are being made aren't made in Colorado. So the headquarters for all of these monolithic, almost monolithic healthcare systems are out of our state. And the leaders that we have in the state have limited ability to make decisions around structures and systems that could affect the whole system. So figuring out how to raise up the power of Colorado's versions of United and Anthem and Cigna and other, I don't want to leave anybody out, but how we can say healthcare is delivered at the local level and you'll be measured at the local level, and then make those issues about how they perform across the spectrum of effective preventive services and effective therapeutic services, and to hold them accountable, I think is the approach I would take. The Hospital Association, long time ago, really started working on this, and they were a little, when Jeff Selberg was still in state, and they were serious about it for a period of time. I think as their leadership changes and they start to think more about the hospital as a center as an anchor institution that can promote the health of the community around them, I think those are opportunities that we could try to work into figuring out how to make public health practice and a population approach more visible and real. There, you know, Jan, I went to a talk, I presented at a talk just a little while ago about the integration of the social determinants of health into healthcare systems. And I think Children's was one of the, well, Kaiser, but Children's was one of the first systems that actually put together an intake tool, screening tool for all new patients that was based around the social determinants of health. And so thinking about how kids are actually going to be able to meet the therapeutic and preventive recommendations from their provider in the context of their social determinants of health is just another area where I can see facilities at the hospital level taking it on. So I think trying to work at the just different levels would be important. The last thing is hospitals do have this community benefit recommendation. Now, it was for nonprofits, but it's now been applied broadly across for-profit hospital care systems as well. And that came with the Affordable Care Act. And I still don't think we figured out the best way to leverage what hospitals are doing and spending on community benefit to better promote public health activities.
So just a comment there, one of our students did some the fact that you gave the emphasis to care and public health. And I think we have a natural ally to do some creative things with family medicine. And that was certainly an interest of Frank Degree, and Mairo Morimoto follows in that same spirit, I think. Let's see, perhaps last question, Tyler. Do you want to go ahead?
Thanks very much. And Ned, thanks for a wonderful presentation. I know you didn't touch on it too much, and I know that it's mostly just an area of interest for me, but I also think it's a driving force in public health right now, is the opioid overdose epidemic. I'm curious to hear your thoughts on strategies to address this issue and how the role of Associate Dean for Public Health Practice can affect change on this topic and for both our community and potentially broader. So thank you.
Thanks, Tyler. And I didn't focus on that. There are a number of activities at the community guide looking into evidence-based solutions for opioid overdose. I think some of them are already in place in Colorado that are policy issues. So our naloxone statutes and rules and regs are actually not bad compared to other states who take a more conservative approach. And so I think there are openings through state policy to really put things together that we know are impactful. I think, we're also novel in having an ability to address syringe exchange to kind of do the downstream problems associated with opioid use. I think the other thing that when I was at the trust, we talked to communities about, though, was moving upstream into why people turn to opioids. And those are social determinant type issues. And having, one example I would say is that if you go to, I would go to a rural community that I know, but I'm not going to say what name, but they're in the San Luis Valley. They have a 90% high school graduation rate. They have very high drug use in new high school graduates, because half of their graduates will move on to higher education, which means half won't. And there's no career, and higher education is traditional higher education. There is no life or career trajectory for 50% of their graduates to gain employment, to learn skills, and to have a trajectory that's fulfilling and provides them with some alternative to turning to other activities such as drug and alcohol abuse. So I think we really need to, I think we're thinking about it in two arms. One is the more conservative, in my mind, approach to providing better treatment options. But I think if we're really going to get a hold on it, we need to work on the determinant, on the upstream issues. And where's public health role in defining where those interfaces are and how we can better address those. I know the school of the Department of Family Medicine is active in the area. And I think to the degree that public health can work with Don Neese and his groups and others into a real life cycle based across the spectrum between prevention and treatment for opioid overdose. It needs to be comprehensive and integrated both between the practice environment and the public health environment.
Great, thanks. Thanks, Ned. We're out of time, and we've certainly had a lot of, you threw some challenges at us, and certainly you had a lot of thought-provoking questions back. So I really want to thank you so much for the presentation, everybody for your questions, and Ned, we're delighted that you're the finalist for this position. So look forward to further conversations, and thanks all.
Thanks. See you all.
Thank you all. Bye. Thanks, Ned. That was good.